First of all, I'd like to thank the organizers of this symposium for inviting me. It's certainly always flattering to give a talk, especially in front of a group of Parkinson patients, since you are all experts, although you probably never wanted to be, in this area. So the topic of my talk, obviously, is non-motor symptoms in Parkinson's disease, and I've learned over the years that a lot of people don't know what we're referring to when we talk about this. When I trained in neurology a long time ago, there was no concept of non-motor symptoms in Parkinson's disease. After all, Parkinson's was a movement disorder, and so doctors concentrated on the movement disorders, the tremor, to a lesser extent at that time, the slowness, the stiffness, the loss of dexterity, the problems with balance, issues like that. And really, the rest of what we now consider Parkinson's disease was not something that was really addressed or even considered. Now, I became very interested in this, sort of as a sort of something that developed because of an interest in something else. When I first started in practice, which was in 1982 when I moved to Rhode Island, I was primarily interested in a problem called tardive dyskinesia, which is a movement disorder induced by antipsychotic drugs. So it occurred primarily in people with schizophrenia. And because I was interested in that, I started working part-time at the one state psychiatric hospital in Rhode Island because their population really was fairly captive. They didn't really move around much because they were chronically ill. And so I could follow them for long periods of time. And while I was there, they participated in a clinical trial of a drug called clozapine, which had been released in Europe but wasn't available in the United States, and was thought to be virtually a miracle drug for schizophrenia, partly because it was more effective at treating psychosis, but also because it did not produce Parkinsonism as a side effect. Now, all of the antipsychotic drugs up until that time, and unfortunately most until this time, cause Parkinsonism in normal people who don't have Parkinson's disease. And if you give those drugs to people who do have Parkinson's disease, they get much worse. So I thought, gee, I make enough people psychotic with my drugs for treating their Parkinson's disease. Wouldn't it be nice if I could treat them for that too, so that we could treat them without causing hallucinations or delusions or other problems? And so I became interested in that drug, and it turned out to be extremely helpful, extremely successful. And I just kept pursuing that and became increasingly aware of these other problems that occur in Parkinson's disease that are not directly related to your movements. And I'll be talking about that throughout this talk. So first of all, I have no real significant conflicts of interest. Not involved in any drug trials now. There is one thing I wanted to mention, which is actually a request for help, okay? So I wrote a book about Parkinson's disease. And I published a book a long time ago about just behavioral problems in Parkinson's, and that you can get out of a library, hopefully somewhere in Florida. But this is a book that hasn't been published yet, and it's a guide, a free guide for people with Parkinson's, and I wanted to make it available on the internet for anybody, free of charge. It includes about 20, 25 videos so that people could see examples of problems with Parkinson's disease. And it turns out not to be so easy to do that. Right now, if you have an Apple product, you can download this from Apple Books. It's called A Free Guide to Parkinson's Disease, a guide for patients and families. There's no advertising, there's no money, it's all completely free. But trying to get it on a more globally available service, especially for people who don't have access to libraries, who are in rural areas, people who are in poor countries. I've worked a bit of time in places where, there are no bookstores, where there are no Parkinson's disease experts, where even getting L-DOPA is a problem, and getting books about Parkinson's is difficult, but people often have internet access. So if there's anybody here, and I'm reading this from what my daughter told me to ask, anybody here with expertise in creating an EPUB with videos and charts that will work if placed on Google Play, please let me know, okay? My email is joseph_Friedman at Brown, B-R-O-W-N, the university, brown.edu, or through the organizers of this symposium. I'm sure you can track me down. So that's a plea. If anybody knows how to do that, let me know, and then everybody will have the book available free of charge. So Parkinson's is considered a movement disorder, but really it's much more than that, which is not good for you. Okay, but you all know about this because almost all of you have at least one and usually more of these problems. It's really a movement disorder with behavioral problems as well as something we call autonomic problems. We can divide the kinds of non-motor symptoms that Parkinson patients have in two different ways. So the one I have up on the slide here is to divide them into those we consider somatic or bodily problems and those we consider behavioral problems. One can also look at the problems Parkinson patients have in the non-motor area as those that are part of the disease or intrinsic, that is the direct result of the loss of neurons in your brain or nerve cells outside your brain, versus those that are caused by the treatment. Those are iatrogenic, that is, problems caused by treatment. So I've divided them here into somatic versus behavioral. And when we talk about somatic problems, we're talking about problems like constipation, problems with controlling your blood pressure, difficulty with bladder function. Some of you, not too many, will have problems with sweating. Half of you probably have chronic pain conditions. Some of you have skin problems. Some of you may have breathing problems. And a problem that I discovered, that I learned about from my nurse, I did not discover it myself, was that many of you have a runny nose that runs all year round. Okay? Your doctors never told you it's part of Parkinson's disease because they didn't know it either. And then there are behavior problems. And these are also often very serious kinds of problems and difficult to deal with. So we all know that depression is increased in Parkinson's disease. And back when I trained, depression was probably the only non-motor symptom that people talked about with regard to Parkinson's disease. And the issue there was whether depression was intrinsic to the disease. That is, it was part of the disease process. It was the direct result of the loss of brain cells in some part of the brain, or whether it was a reactive sort of depression. Wouldn't you be depressed too if you learned you had a progressive, incurable, sometimes disabling disorder? And that was really the main issue that people addressed when they talked about behavior in Parkinson's disease. They didn't recognize that anxiety was a very common problem in Parkinson's disease. 40 to 50% of people with Parkinson's disease suffer from anxiety. Now, sometimes your anxiety is well placed. You're worried about whether you're going to be on or off this evening when you're going out for dinner. You're worried about whether you can go to some, social event. There are a lot of things to worry about, of course. But anxiety is increased in Parkinson's, and it often increases before you know that you have any motor symptoms. It's part of the disease. That was not recognized. And actually, that's often one of the most bothersome problems that Parkinson patients have, because when they're anxious, they're difficult to be around because they're always worried about something, and it's very hard to be around people who are anxious all the time. One of the unfortunately incredible things about the doctors who take care of people with Parkinson's disease is that there have been no studies on the treatment of anxiety in Parkinson's disease. None, despite the fact that it affects about 40 to 50% of Parkinson patients. And unlike anxiety that occurs in the general population, which affects women much more than men, and typically starts in women who are in their early 20s, late teens, anxiety in Parkinson patients develops shortly before they develop the symptoms, the motor symptoms of Parkinson's, or a time after, and it affects men and women about equally. Fatigue is a very common problem in Parkinson's. I learned that from a patient. You learn most of your important things from our patients. It was a patient who then was in his 40s. At that time, he was a little older than me, but not much. He worked full time. And he told me that the worst thing about his Parkinson's disease was the fatigue. That at the end of a day of work, he couldn't do anything but lie on the couch and do nothing else. And yet his Parkinson's wasn't really all that bad. He was able to work an 8-hour day. He was able to do his chores. He was able to do what needed to be done. But yet the fatigue was wiping him out. And I learned by asking other patients, this is very common. Half of people with Parkinson's disease rate fatigue as one of their 3 worst symptoms, including all their motor dysfunction. Sleep disorders. Something like 90% of people with Parkinson's disease have a sleep problem. Either they sleep too much or they can't sleep at night. Some of them act out their dreams in the most bizarre ways, particularly dreams that are violent, where they may jump out of bed, they may beat their bed partner because they're having a dream. During normal or dream sleep in normal people, you're supposed to be paralyzed, except for your breathing and your eye movements. Hallucinations I'll talk about at the end. Those are induced by the medications. Generally about 1/3 of Parkinson patients who take medications for their motor dysfunction will have hallucinations. Dementia is a very common problem that occurs generally after many years of having Parkinson's. Doesn't affect everybody, but is a very major problem. And our medications for treating that do exist, but they're not as good as we would like. You've all heard probably about compulsive behaviors that occur on dopamine agonists, people who start gambling or becoming hypersexual. I'll give you a video example of that at the end. And then apathy is something that occurs in Parkinson's, which is a very common problem that a lot of times causes difficulties in families, more for the people around the patient than for the patient himself, because they don't care. So I'll take just a couple words about pain, because that's so common. There was a study that was done just a few years ago looking at pain, just pain in general, chronic pain, in people with Parkinson's, and they compared them to age-matched controls. So that is a comparison between men and women who are about the same age. And Parkinson patients suffered from pain about twice as often as people who didn't have Parkinson's disease. And the reason for the pain, in most cases, is the same as occurs in other people. It's just more so. So what causes pain in most older people? Well, usually it's something related to arthritis. And Parkinson patients have arthritis just like everybody else. I don't think they have more arthritis, but the problem with their arthritis is that as a result of the Parkinson's disease, their posture is not normal. They're stooped forward. If you're stooped forward, the strain on your lower back is much increased. If you think about your spine as being something like the mast of a sailboat, when the mast is up straight, it doesn't take much force to keep it up straight. But if the mast is tilted slightly, in order to keep it from falling over, the amount of force you have to use down here, which for a person would be their lower back, of course, is much increased. So the amount of pressure on the bones in the lower back is much increased. In addition to that, when Parkinson patients walk, they don't walk normally anymore. Besides being stooped, they take small steps, and they often keep their knees somewhat bent, so that the dynamics of how they walk, the biomechanics, are altered quite a bit. So the stress on their joints is quite different than what the body evolved to do for normal people. So that's going to aggravate all the arthritic sorts of pain. And then also as a result of the posture, with the head being forward, most or a large percentage of Parkinson patients have pain in their posterior, in the back of their neck. And then there are some people who have pain which we think is directly related to the Parkinson's. Sometimes it gets better when they take their L-DOPA, and a lot of Parkinson patients have chronic achiness, particularly in the large muscles of their thighs and their shoulders, as a result of their rigidity. So Parkinson patients have pain, and yet we don't think of that. In fact, whenever we talk about treating Parkinson's disease, we're always talking about levodopa, about dopamine agonists, about entacapone, about all of these drugs for treating the motor symptoms. And yet, the point I am trying to make is that these other symptoms are part of Parkinson's disease as well, yet when we treat the anxiety, we tell you, well, I'm giving you this for anxiety. When we treat the depression, we're giving you this for depression. It's really all Parkinson's disease, and unfortunately, and I really mean this, unfortunately, these are not dopamine related. So when your doctor, and many doctors oversimplify this, say, well, you know, Parkinson's disease is a dopamine deficiency state. We give you more dopamine. We correct the chemical imbalance in your brain, you know, and everything will be okay. And you take the medicine and things improve, but they're not okay. It's because a lot of the problems that occur in Parkinson's are not simply dopamine. They're related to other chemicals, other circuits, other connections in the brain that are much more complicated than simply losing the dopamine stimulation in the brain. So now I'm going to talk about autonomic symptoms. The autonomic nervous system is the part of the nervous system that controls unconscious bodily functions. So you don't control your heart rate, you don't control your sweating, you control your bowel movements to some extent, and certainly you control your bladder to some extent, but you don't control your blood pressure either. So these are functions that are occurring without your conscious control, and your brain and your spinal cord are strongly involved in controlling these functions so that they work properly. Now, a large percentage of people with Parkinson's disease become constipated, and that's the result of more than one problem. One problem, of course, is that you're not moving as much as you used to, and that's important. But probably a more important factor is that the nerves that go to your intestine, that get the muscles to move, to squeeze and force the food from one end to the other, those nerves are directly affected by the Parkinson's disease. We've seen that in biopsies that are taken from the colon. Certainly we've seen it in autopsies, that many of the nerves that go to the gut have the same pathology that Dr. Hauser showed you when he showed you the alpha-synuclein stains in people with Parkinson's disease. So that the nerves that go to your gut, the nerves that go to your esophagus, your swallowing tube, and to your stomach and your gut, they're all affected in Parkinson's disease, and they slow down gut motility. Dopamine does not help that because those nerves are not nerves that secrete dopamine. So constipation is a big problem, and it's something that needs to be addressed early, and the best treatments for that are increasing fiber. Exercise, of course, but increasing fiber is probably the most important. Bladder control is a more complicated sort of issue because people with Parkinson's disease develop symptoms of an overactive bladder, which means they have urgency and frequency. So urgency means once they get the urge to go to the bathroom, they need to go quickly, okay? Because their bladder, which is like a muscular balloon, it's a ball or it's a sphere that's really just a muscle. And when the muscle gets stimulated, it starts to contract. And when that happens, you get the urge to urinate. So with Parkinson's disease, you have urgency, the contraction is strong, and it starts to contract when you have a smaller amount of urine in your bladder than used to trigger a response. So now your bladder is only half full, and you have a strong urge to urinate. You need to get to the toilet in a hurry, and of course, doing anything in a hurry when you have Parkinson's disease is not a good thing. Complicating this, however, is the fact that as we age, we get other problems that also may cause symptoms of an overactive bladder, such as an enlarged prostate, if you're male. Enlarged prostates cause the same sort of symptoms, and the treatment for them is different than the treatment for the overactivity from Parkinson's disease. Women often have difficulties either as a result of pregnancies or as a result of repeated urinary infections, where they may get the same symptoms as well. So it's unfortunately a somewhat complicated process, so that it needs to be evaluated more than just hearing it's overactive bladder and related to Parkinson's disease. It may be, but it may not be. Now, orthostatic hypotension is a significant problem, and I seem to be encountering this more and more. So orthostatic means standing up. Hypotension is low blood pressure. So many of you are treated for hypertension, and all of you have friends and relatives who are treated for hypertension, which is high blood pressure. And you're probably aware that over the last 5 years or so, the numbers that the doctors consider good for you are lower than they used to be. Well, a problem in Parkinson's disease often because the nerves that go to your blood vessels, that tighten them up or loosen them up, the nerves that go to your heart that make it control your heart rate and how strong your heart pumps are affected by the Parkinson's disease, that they don't function normally. And a very common problem in Parkinson's disease is orthostatic hypotension, that is low blood pressure when you stand up. Now, when normal people stand up and they have low blood pressure when they stand up, they feel lightheaded and then they faint. That happens to many people with Parkinson's disease as well. However, it often doesn't occur for 2 or 3 minutes. And when it does occur, instead of simply feeling lightheaded like you're going to faint, very often the legs start feeling rubbery or wobbly, or you just go down without knowing why. That can be a symptom of orthostatic hypotension, even without feeling the lightheadedness or faintness that used to occur when you were younger if you got lightheaded. The only way to determine that is to check your blood pressure sitting and then after you've been standing 2 or 3 minutes. But it's a common problem in Parkinson's. Compounding the difficulty of treating it, however, is the fact that if you check your blood pressures, you'll find that they often bounce around a lot during the day. And you may be in a situation where the blood pressures actually are higher than your doctors want at some times and lower than they want at other times. And when you lie flat at night, they're high. We call that supine, which is lying down, hypertension. So a common problem in Parkinson's is to have normal blood pressure when you're sitting, a drop in blood pressure when you're standing, and then when you lie down, it's high. So it's a complicated thing to treat, but it is treatable, and it's a common cause of falls that always needs to be assessed if a person starts falling without clear explanation in terms of their mobility and their balance problems. The medications that we give for Parkinson's, unfortunately, including L-DOPA and the dopamine agonists, sometimes make it worse, and yet you still have to take the medicine. The treatment for that is with medications to raise your blood pressure, and we use them quite a bit. Dementia refers to a decline in a person's ability to think, problem solve, and with their memory. It's not Alzheimer's disease, okay, that people with Parkinson's who develop dementia develop. You can. Having one disease doesn't protect you from another, but the dementia that occurs in Parkinson's is different than what we see in Alzheimer's disease. In Alzheimer's, for example, when you ask people to remember things and they don't remember them, they can't remember them, there's nothing there. It's like they erased their memory track as soon as they laid down the memory. Whereas with Parkinson's, they may not remember when you ask them, but a minute or two or an hour or two later, they will remember it. That the memory is just not as accessible. People with Alzheimer's disease usually have language problems. They can't come up with the right words for things. They may make up words that don't really exist. And that doesn't happen in Parkinson's disease. But Parkinson patients are often depressed when they become demented, and Alzheimer patients usually aren't. Parkinson patients often have more insight into their memory problems than people with Alzheimer's do. So there are differences that we can see. Depression. Depression means you're feeling sad. And there are lots of signs that we look for, that is, changes that a doctor sees when he's diagnosing somebody with depression. In normal people, a lot of the signs that are used for saying that a person is depressed actually are features that we see in Parkinson's disease in people who are not depressed. A soft voice, well, that's common in Parkinson's disease. Fatigue, that's common in Parkinson's disease. Sleep disorder, that's common in Parkinson's disease. Weight loss, that's common in Parkinson's. And yet you'll see people who are not depressed at all with Parkinson's who have all of those symptoms. So when an NIH panel convened to come up with a definition for depression, how do you define depression in somebody with Parkinson's? Basically, everybody agreed that if the patient says they're depressed, that they're sad, that they're melancholic, they're depressed. And the other features that we look for in other people really are not reliable in Parkinson's. But an important point, because this is a very common problem in Parkinson's that I see, is the distinction between depression and apathy. Apathy is a common problem in Parkinson's, particularly in people who are starting to have memory dysfunction. Apathy means they're not interested, they don't care. Depressed people often don't care, but often they're irritable, they may have somewhat labile affect, and usually they feel sad. Whereas apathetic patients really just lose interest in everything, and so they begin by not caring, what's on TV, then they don't care if the TV is on at all. They don't care if, the only thing they care about usually is having their grandchildren visit, and then that wears off in a few minutes, and they don't care much about anything more after that either. And the problem here is that apathy is untreatable currently. We don't have medications to restore the normal personality, the previous personality, the things that made that person unique, that made them, the person that their wife or husband married. Those kind of things have kind of burnt out as part of the apathy, whereas depression is a treatable condition, we believe, so that there is hope that we can treat that and make people whole again, at least in that area. So I'm going to switch gears because I have 8 minutes left and I can't run over. So I'm going to switch to hallucinations, which is really an area that I'm most interested in. That's why I kept it for last, so that otherwise I might not have gotten through the rest of my talk. So here's a patient who's going to describe her hallucinations to you, and then I'll tell you a little bit about hallucinations. You can read that now, please.
I give permission to Dr. Friedman to show my video to other health professionals.
Thank you very much. Can you describe the hallucinations that you've been having?
Lately, I have 2 cats that lay on my feet. They feel furry, but they don't say anything.
But you see them as well?
I see them, yes.
And you said there's another image that you have.
I have the image or the feeling that there is someone looking over my right shoulder. He's all white.
He sees a man by her right shoulder.
It's a male, and he does not say anything.
And you mentioned something about his face.
There is no face.
But he doesn't have a
features.
face. No features, but it's not scary.
No.
And we just discussed that if you could get rid of the man and you just had the cats, you would prefer keeping them, even though they're hallucinations, than getting rid of them. Is that correct?
That's correct.
Okay. Thank you very much.
You're welcome.
So you may not, did you understand that or not? You did, okay. So she sees 2 cats and a man, okay? The 2 cats are in front of her, but she also feels them. So she has visual hallucinations, and she has tactile, meaning touch hallucinations. She can feel things. People who are treated with medications, as I mentioned before, 30% of people who take medications for Parkinson's will have visual hallucinations. They see things. Often their peripheral field, they'll see a shadow go by, or they'll see a little animal run by, but when they look at it, there's nothing there. So those are, we call passage hallucinations. Sometimes they have this very peculiar sensation that I've never heard of in another disorder, in which they feel that there's somebody around them. I mean, all of you have sometimes thought there was somebody in the room with you, or there was somebody behind you, and you turned and looked. But once you look, it's done with. You know there's nobody behind you. But with Parkinson's who have this problem, they often think there's somebody just out of sight, so they'll turn around and they'll do it a lot because they feel that there's somebody there, and it's never somebody who's going to attack them. It's never a dangerous situation. It's somebody's there, or there's an animal there, and it's no big deal, but they're just curious what it is. Or they may see glimmers of little lights off their eyeglasses as if there's somebody behind them. So in her case, she saw cats, but she also saw this man without a face. And the man without a face wasn't frightening to her. I mean, partly because she got used to him, she's seen him a lot. But these things usually, they're rarely frightening to people. And the cats, she liked. And I asked her at the end, if you could get rid of the man, would you like to keep the hallucinations of the cats? And she said, yeah. I mean, if you like cats and you don't ever have to take care of them, you don't have to feed them, what's the big deal, I had a patient once, when I asked him about hallucinations, he smiled. And he said, yes, every night I see this baby. And then he said, and the baby is very good. He never cries. Because he has the visual hallucination, doesn't have an auditory hallucination. But the hallucinations can get out of hand. And although the visual hallucinations are very common, and they're treatable, by the way, partly they can be treated by reducing medicines oftentimes, or when you can't reduce medicines, we have drugs that are useful in treating them. A smaller percentage, so about 30% of Parkinson patients on drugs will have hallucinations. About 5 to 8% will have delusions. A delusion is a false, irrational belief. The ones you hear on television, the FBI is tapping my phone, I get messages from space, things like that, false beliefs. But in the Parkinson's disease, unlike the visual hallucinations, which are occasionally entertaining, but usually, emotionally neutral, somebody walking on your lawn, you don't really particularly care about that. The delusions are typically paranoid in nature. The most common one is spousal infidelity. Now imagine the distress that causes to the patient thinking that their husband or wife, and it works for both genders, is cheating on them, and the difficulty it creates for the spouse who's spending all their time caring for the patient, being accused of doing these things, which are totally irrational because they're never out of sight of each other 24 hours a day. Very often, these issues are not discussed with the doctor or the family because everybody's embarrassed. So the doctor needs to ask about them. Okay, so it's one of the things I ask about. And, families will often be, surprised. Like, why did this guy ask that crazy question? Which turns out to be true. So that's a very important issue because it is treatable these days, at least to a large extent, and occurs in a large percentage of patients. I have 2.5 minutes. So that's an iatrogenic problem. That's caused by the treatment. And I got interested in this because it turned out that I single-handedly probably created more psychotic patients in New England than any other doctor. So I was at least helpful in trying to treat it, okay? Now, the next also iatrogenic problem, which I'll close with, is the compulsive behaviors, impulse control disorders they call them, but they're really compulsive behaviors. You've heard of people who take dopamine agonists. So those are pramipexole, rotigotine, the Neupro patch, and ropinirole, Requip. So Mirapex, Requip, rotigotine patch are the drugs that are primarily implicated in this. And it was discovered only after the drugs had been in use for 20 years because who would connect a patient who's gambling with a drug that they'd been taking for 5 years? I mean, who would make that connection? But that connection was made, and it turns out to be accurate. Let me see, can we play that video? So first of all, I'd like to thank both of you for agreeing to this interview and for allowing me to show it in front of doctors and other health professionals. So first I'm going to start with your daughter to describe what she went through with this problem with the gambling, okay? And then I'm going to ask you to say a few words too.
My father's had Parkinson's for over 10 years. At the beginning, we were finding that he was spending unnecessary money. It has led to us taking over his finances. He has totally wiped out his life earnings, which was about over $250,000, with visa bills over $25,000 that had to be repaid. Now he's only allowed so much money per week. And with this, as soon as he gets money in his possession, he will spend it on things, like food and everything, but he will also lie and spend it on scratch tickets, which he claims is not a form of gambling. It's just a few tickets. And when asked about his life savings, he will say that he doesn't cry over spilt milk. And just yesterday, he said that he took $25 out of the bank. I asked him what it was for. He told me it was for dry cleaning. When I asked his help, what the $25 was for, did he pick up dry cleaning? He knew nothing about that. And then my father admitted that he spent the $25 on scratch tickets. So this is just one of the thousands of examples how he continues to lie about how he uses the money that we give him and allow to him.
And he didn't have a gambling problem before the Parkinson's?
Absolutely not. In
Right.
fact, when he used to go to Atlantic City a few times with our mother, he used to get angry when my mother used to play the nickel machines.
Okay.
And then he used to gamble a few games of baseball, but that was like a neighborhood pool but it was never ever as much as bad as this.
Okay. Well, thank you. And what's your take on this?
Well, I must admit that once I started with the Mirapex,
Yeah.
my gambling habits became very attractive.
And what do you see, how do you see it now? I mean, your daughter says it's still happening.
I'm not gambling that much money.
Yeah.
I do buy a scratch ticket. I do play the lottery when the earnings are, when the winnings are like $100 million.
Yeah.
Played a lot.
Do you think she's exaggerating?
She's exaggerating.
Yeah. But you did lose all your life savings, right?
It wasn't $250,000.
But it was a lot of
I
money.
had $125,000 in my bank.
But you lost that.
I lost that.
Okay. So that's still a lot of money, I think,
Yes, it
right?
is.
Okay.
I'm very sorry I lost that.
Sure.
And
But what about the $25 you spent yesterday?
$25 I spent yesterday. I spent $15. So I had gone into a Chubby's shack, and I had fishing chips, and I had...
Okay, so this was a man who was single. His wife had died a while back, and his two adult daughters were taking care of him and controlled his money. And so he was on an allowance, and he would go to his family members, his cousins, and say that his daughters were stealing his money and that he needed money from them because he couldn't eat otherwise. Meanwhile, they, of course, were controlling his money as best they could. And, as he said, he didn't lose $250,000, he only lost $125,000. So it was no big deal, despite the fact that he no longer had a retirement. And he was a guy who did not gamble previously. So this is an extreme example of the kind of problem that occurs sometimes with these drugs, with people who had previously normal behavior starting to do something compulsively. And you've probably all heard about the gambling and the hypersexuality, but there are a number of other things where people do very unusual and highly focused activities on a very compulsive basis. So one of my colleagues had a patient, for example, who couldn't stop eating Braeburn apples. I actually had never heard of Braeburn apples, but there is a species of Braeburn apples. She gained 20 pounds eating Braeburn apples. And when she stopped taking the medication, she lost the weight and stopped eating apples. I've had patients who did compulsive hobbies. So one guy who couldn't stop fishing. He was an avid fisherman before this, but then he started doing things that were really crazy, like fishing off the rocks during the winter, in New England, things that were really insane, that he only recognized as being crazy after he stopped taking the medication. I had a patient who baked a cherry pie every night, and he didn't like cherry pies, and he didn't eat them. So people can do unusual things, and one of the interesting things about this is it doesn't develop right away. It's something that develops after patients have been on the drugs for quite some period of time. So one of my patients recently told me, she said, you keep asking me about whether I'm doing anything compulsively. She said, well, recently I noticed that when I go to work in the morning, that I have to change my clothes. That no matter what I put on, I have to change them 2 or 3 times till I find an outfit that I think is right. And she never used to do this. And we cut down her drug, it went away. So, in conclusion, I want to say that Parkinson's is, unfortunately, a very interesting disorder. As my chief, when I was training, said, it's never good to be an interesting patient. However, from a doctor's point of view, it gives us a lot of interesting things to ask about and inquire about and learn about. And what's perhaps most interesting to me is the number of doctors who preceded me, who were smarter than me by a lot, who never recognized this. And it always makes me wonder what problems I and my colleagues are missing now. And I think it's up to you to inform us about them, because we often don't know what questions to ask. But when you think about Parkinson's disease, I hope I've gotten you to agree that it's more than just tremor, it's more than just tripping, losing your balance. Those are all very important. But there are other aspects to the Parkinson's disease that are just as important, often more important, and you have to discuss these issues with your doctor. And the only way to do that is to know about Parkinson's disease so that you know which problems are related and which aren't, and you can formulate the questions you need to ask to have yourself treated in the best possible way. Thank you.